you everyone for being here. For today's grand rounds, we have Stephen Zuckerman, who really doesn't really need an introduction, but I'll do one anyways. So today he'll be talking about DBT interventions for the treatment of substance use disorders and addictions. And Stephen is a graduate of Brooklyn College. He achieved his bachelor's and master's degree in psychology, and he has had a variety of leadership positions, throughout the state of Connecticut. Previously, he was the VP of operations for Hartford Healthcare's Rushford system. And now, as everyone knows, he is our president and chief executive officer. So without further ado, we're really excited to have you here, and I'll turn it over to you. I'll be in the background if you need anything. So thank you, Stephen.
Sounds good. Thank you all. Thank you all for participating today. So this is my first time doing this particular presentation. This may take an hour. This may take 10 hours. So we'll have to sort of play it by ear how things go. What I would ask is that people hold their questions to the end. If by chance I do not have enough time for questions based upon how long the slide deck, which is 34 slides, may take, you all have my email address for those who work for the organization. For those that don't, I understand from Darcy, there's about 12 external people from the organization today, which is great. I'll provide my email address at the end so that folks can send questions if we don't get to that portion. All right, hopefully that sounds good for everyone. All right, let's get into it. And just as an aside, for those who know or don't know, especially those who are outside the organization, I do a DBT group once a week at our Henderson Johnson Clinic in Hartford, and have been doing that at the org for about 4 years now, and have been doing DBT probably for about 18, 19 years. All right, let's roll. So DBT was developed at the University of Washington in the late 70s and early 1980s to help borderline personality disorder, with the first treatment manuals published in 1993. So when I got this training, if you didn't have a diagnosis of BPD, this was never even considered for you. Over the years, it has grown, and rightfully so, to be very impactful for those with many different diagnoses. And for that matter, I don't have a particular diagnosis, at least one that I know of, and I use these skills every day. So these skills are very beneficial in all aspects of life. So just to put that out there. The founder, the person who's credited as being the creator, for those that don't know, is Marsha Linehan. One of her outposts where I was trained about 17, 18 years ago is in Northampton, Massachusetts. Large contingent of DBT trainers in Northampton. So DBT places greater emphasis on behavioral interventions compared to cognitive interventions. So it's guided by a different theory than CBT, and we'll talk about that in a little bit. Like CBT, DBT is directive and change-oriented and fully embraces acceptance-based strategies. That's a key thing, and we'll talk about radical acceptance and other forms of acceptance later on. When you think about being a clinician, when you think about being a counselor, the most successful relationships with the patients are one that embraces acceptance, okay? Not consequences, acceptance. Okay, so major DBT ingredients, the guiding theories and philosophies of DBT. Biosocial theory, so there's biology, and then there's your social environment. The client-therapist assumptions that they're bringing to the table as the therapist. And dialectical philosophy, key thing about DBT. Well, what does dialectical philosophy mean? I get that asked all the time. What is dialectics? What is dialectical philosophy? Philosophical argument that involves some sort of contradictory process between opposing sides and helping individuals get to some middle ground where they could move forward. A lot of the problems for people who are in DBT, it's the extremes. They take extreme viewpoints on different situations, and it's creating this synthesis, helping a client get to some middle ground. A dialectical example of when two seemingly conflicting things are true at the same time. It's snowing and it's spring, right? I think I saw some snow flurries last weekend during Easter, but it's spring. So again, conflicting things can be true sometimes at the same time. And it's working with our patient to be able to understand that and how to get to some middle ground, some synthesis of these opposite viewpoints. Treatment structure. therapy, individual, and group. I don't do any individual work with the clients I see right now, but in typical DBT, they're with a DBT individual therapist, and they attend a DBT skills group. Right now, the clients I meet with are just doing the skills group. And again, that's fine, and we'll talk about that later on. Skills training, that's the work I do with the clients. 4 modules: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. That's what the clients go through when they're with me. Each module, if you're very focused and you're working through it, each module takes about 4 to 6 weeks. So if a client wants to be in this group with me from beginning to end, you're talking about from anywhere from 24 weeks to 36 weeks. Long commitment, long period of time. At Root, I have a number of clients that are probably going through their 3rd or 4th frame of going through this over and over again. They want to continue to improve on their skills. So I don't kick anyone out. If they want to go through it again when they're done, they go through it again. Major DBT ingredients continued. Acceptance strategies, validation, nothing more important. Validation is a key thing. Think about our own lives. When we feel validated and we feel heard, we're more apt to have a positive experience and better chance for change. Validation, very key, no matter what the therapy framework is. Mindfulness, so being in the moment. Hopefully all of you that are on this in this training today, you're not playing on your phones, you're not doing side work, you're focused on this training. It's being in the moment. That's a major concept in mindfulness. Radical acceptance. Radical acceptance we'll talk about more later on, but essentially what radical acceptance is pretty much accepting something unconditionally. Trauma. Trauma is a big thing for many of our patients, and radical acceptance is a hard one. What radical acceptance does when you get to that point, it essentially gets rid of the suffering. And that's the big thing that holds many of us back. It's the suffering. So if I went through a trauma experience, a very traumatic experience, be it sexual abuse, you're not condoning what happened. But in order to move away from the suffering, you have to get to a point of radical acceptance. And there's skills that will help get you there. And we'll talk a little bit about that later on during the training. Change strategies. So there's acceptance strategies and change strategies. Behaviorism is one. Contingency management. We talk a lot about contingency management in the methadone treatment programs, and dialectical strategies. And we'll talk more as we go through that. This is a question I get asked a lot too. How does DBT differ from CBT? CBT focuses a lot on thoughts, changing thoughts to change behavior. That's really the main premise of cognitive behavior therapy, working to change thoughts to change behaviors. DBT, it's working to change emotions, adapt emotions, work through emotions to change behaviors. Major distinction between the two. Biosocial theory of DBT and addictions. People experience emotion dysregulation, sensitivity, reactivity with a slow return to baseline. That's all of us, okay? All of us experience at some point or another emotional dysregulation. Emotional dysregulation is exacerbated by invalidating environments. Well, what does that mean? So if I'm in an environment and I'm told on a regular basis, your feelings are stupid, you know, get over that trauma. Addiction is just a lack of willpower. It's BS. So is my emotional dysregulation going to be exacerbated by that invalidating environment? Absolutely. Absolutely. Invalidating environments that we live in are often the cause for a great deal of emotion regulation. For our clients, many are duly diagnosed, mental health and addiction, they suffer from this even greater. They don't have the skills. So relative to addictions, ineffective behavioral responses provide short-term reinforcement, but contribute to long-term dysregulation. Think about that with addiction. We'll hear from our patients many times. If I use, I get to escape all of that. I get to escape the moment. So they're getting what? They're getting short-term reinforcement. Absolutely. That use gets them that short-term reinforcement. But what is it doing in the same breath? It's contributing to long-term dysregulation. So we got to help them change behaviors. Effective behavioral responses may provide less immediate reinforcement, but provide long-term regulation. Working through things is tough, especially in the stages of change and the early changes of treatment. Not going to get a whole lot of reinforcement going through having to deal with life. It's tough, but that's going to help them towards long-term regulation. So as you're thinking about questions, just make sure you're jotting them down so we can talk through them at the end, or you can email me, because this will trigger a lot of things for people as far as questions. I just want to make sure we get through all of the slides because I have no clue if we will. All right. Slide 7. Essential 5 functions of DBT for co-occurring disorders. These are essential, really for DBT. Include clients' motivation for change. So a number of you may be trained in motivational interviewing. Can be very helpful. That's a separate clinical framework. But if there's motivation for change, every client that's really coming into our organizations, no matter where you work, they're motivated for change. That is a big first step. So use that, and motivational interview techniques can really help with that. I know some of the background around motivational interviewing, but I'm not formally trained in it. Enhance clients' capabilities, skills training. The main component of DBT are those skills training groups around those 4 modules: the stress tolerance, emotion regulation, mindfulness, and interpersonal skills. Help clients generalize skills, behaviors to their natural environment. That's a big thing I hear a lot. We're in group. I'll hear, Stephen, this makes so much sense. But when I get in those situations outside of the clinic, outside of the organization, I just can't use those skills. So it takes a while. It takes a while to be able to adapt what you're learning in a setting and being able to use it in real life. So an important part of DBT, I'm not doing it here with my clients. So I'm not doing full-fledged DBT, are diary cards and behavioral analysis. You're going to learn a bit more about that as we get through further through the training. So diary cards and behavioral analysis. So it's DBT individual session, it's DBT skills group, it's diary cards and behavioral analysis. Not doing diary cards and behavioral analysis, and I'm not doing individual sessions on DBT with my clients. The 4th component, very important in true DBT, consultation groups. So every DBT trained therapist has a consultation group. It could be weekly, it could be bi-weekly, with other DBT trained therapists, formally trained therapists, where they meet and they talk about the work of DBT, the structure, some of the problems. It's your peer group, and that's a DBT consultation group. So again, if I was doing this to the nth degree, as Marsha Linehan would want, I'd be in a consultation group of other DBT trained therapists. Structure the treatment program and environment. There's rules, there's expectations. I make sure that the clients know that at the outset and as new clients come in. DBT is an open group, it's not a closed group. So what does that mean? I have clients coming into DBT at different points in time. They might be coming in the middle of one module. That's okay, it's an open group. They continue to stay until we go all the way back around where they're completing everything. It's not closed. I don't have it closed where everyone participates and then no one's allowed in until everything is done. Open. Anyone can enter at any time and they just stay until we come back around to where they started. Open group. That's why internally, as you know, you're welcome to make referrals at any point in time. Dialectical philosophy, where does this come from? Dialectics originated with early philosophers. Big thing, no position is absolute. Each position has its own wisdom of truth, if only a kernel at times. Dialectics allow for subjective truth. That's a big thing. Really working with the patients and understanding what their subjective truth is. I relate a lot of this to, if you want to think about a real life example, think about the vaccine and all of the different opinions in each person's subjective truth. You could ignore, you can shame, you could yell, but you're not going to get anywhere. So dialectics allow for the subjective truth and try to be able to work with that. Opposite tensions are interconnected, interrelated, and defined by each other. The synthesis of opposites through understanding various contexts and seeking a workable balance leads to change. That's the big thing. It's taking clients, some of our clients, again, a borderline personality disorder, when this originated, we had folks that really took the opposite extremes of things. And it was very important to work with the BPD population to have them come to some synthesis, have them come to some middle ground. And that's a lot of the work of DBT. Through understanding varying contexts, that there's different ways to look at things and seek a workable balance. How do you get that patient to seek a workable balance? Major component. When you get to help them seek a workable balance, that's what's going to lead to change. Not that polar opposite situation where they can't move off of. Change is continual, right? We know that just in the work we do. Forget about our patients. Change is continual. Evolution is continual. We have to be fluid. We have to be able to move with change, just like our work. Think about the folks who are on here from Root Center, the growth, the change. You have to be fluid. You have to be able to evolve. No different than in DBT. Dialectics allow for subjective truths that do not need to hold up to logical analysis. Okay, it's a big thing. Someone, again, going back to the vaccine, if someone has an opinion, and maybe it seems to us there's no logical analysis to make that hold up, you have to be able to work with that as the counselor to validate their subjective truth, but how are we still going to help them move forward? So dialectical synthesis and DBT. We talked about this, acceptance and validation, but change and challenge. You can accept and validate, but know that you have to be able to change, and we challenge our patients. That's fine. The Serenity Prayer is a perfect example of this. All of us probably know the Serenity Prayer pretty well. What is it all about? It's all about acceptance and change. It's a lot of what DBT is. It's acceptance and change. Balancing emotion and reason. For those who are familiar with DBT, we'll talk a little bit about this later. Wise mind. That's what wise mind is. It's balancing emotion and reason. If everything about you is acting on emotions and you're all about emotion with no reason, it's going to be a lot of dysregulation. The other synthesis in DBT, doing one's best and needing to do better is a primary assumption, right? We know that many of our clients at different points in time are doing their best. Do they still need to do better at times? Yes. It's okay to be doing your best and working with the patient and knowing you still need to do better. How do we get there? It's a primary assumption. It's also a collaboration, an active client and an active therapist. You need to be an active therapist. For those who have been with me in DBT groups, I've had a number of counselors who participated with me, who've been my co-facilitators. I'm an active therapist in that group. Very active, very important. The other synthesis, goals of therapy and or the program, and goals of client. Okay? Think about individualized treatment plans. There are goals of therapy, but we got to make sure that the synthesis is there with the goals of the client. What are his goals? What are her goals? So the synthesis of the two, the goals of therapy and the program, and the goals of the client. Dialectical dilemmas with co-occurring disorders. There's lots of them. Wanting yet resisting change. Probably the biggest one. Think about all the work that many of you do who are clinicians who work with patients. We know that so many of them want it desperately, 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 And we get so caught up in times, they want it so bad, but why are they resisting? It's hard. Mental health diagnoses, addiction diagnoses, change is hard. So I truly believe that they do want it. And yes, there seems to be resistance, but it takes time. It's a lot of work, but that's a major dialectical dilemma with co-occurring disorders. They want it, that's why they're there, okay? They're in front of us because they want that change, but we get frustrated too as clinicians. We're human. We know they want it, but we see so much resistance. So it's a major dilemma for us. Using when it actively causes harm. It's a major dilemma as a counselor too. You can't figure it out. They're using even though it's continuing to destroy their life and cause them harm in their relationships. Okay, it's a dilemma. Using even when it actively causes harm. How do we help work through that dilemma? Having goals or values conflict with behaviors. We've seen our patients talk about their values and who they are, but yet we've heard from them engaging in some behaviors that if they were in a place where their sobriety was in a better place, they would never think to engage in some of those behaviors. Major dilemma for the patient, knowing that they have these values, but their addiction is destroying those values and going opposite of what they truly want to do. Another dilemma, we've seen this with many patients, taking a minor lapse to an extreme relapse. Helping patients remove triggers in their life, so people, places, and things, whatever they may be, but also helping those patients, we can't remove every trigger. So there's going to be triggers we simply can't remove. So it's not just, it's removing the triggers we can, but helping our patients learn to deal with the triggers that are not easily removed. It's a dilemma, but it's easily something that we can work through. This is a big one that we go through oftentimes. Treatment being both supportive and accountable. Supportive is the sort of the key framework for any therapist. But we also have to hold people accountable. We know that. If we're not holding them accountable, we're just keeping them in a place that's not going to help them move forward. Life has consequences, and we have to help them understand that accountability. But it never takes accepting and being supportive. I know that loss of the loved one that you experienced last week was extremely difficult. But going on a rampage in your home and destroying all of this property and now having a domestic violence charge is not okay. We have to think about what skills we could help you adapt from DBT to make sure this incident, which can happen again, we have loss, won't lead to such an extreme outcome. So that's being supportive, but making sure they're held accountable. DBT views of abstinence. Not all clients can be abstinent at the beginning of treatment. We know that. And abstinence is a goal of treatment. Yes, I think the goal of any treatment would be that there's long-term sobriety and there's no use. But we know that many of our clients cannot be there. I have a number of clients who've been in my group now for 3.5, 4 years. They're still using every other day, every day, but they're still coming. They're improved. They're living a more productive life, but use is still unfortunately a part of it. So this is where harm reduction comes into DBT's view of abstinence as well. Not all clients entering treatment have the skills to maintain abstinence, absolutely. We have clients come into DBT, it's hard enough for them to even get into a group, get into counseling, let alone maintain abstinence. Commitment to abstinence happens with realistic timeframes. Therapists take a non-judgmental approach to relapse. Anyone who's been with me in DBT knows, any patient, any counselor throughout the years knows, extremely non-judgmental. I tell every patient, I don't care if you used yesterday, I don't care if you used this morning. If you're able to come to group and be coherent and be able to actively participate, I don't care about your use. I can care about your continued recovery and your engagement in the process to get there. Extremely non-judgmental. As a result, over the years, patients have been very honest, been very forthcoming. They're not going to get kicked out. They're not going to be degraded in any way. They know that this is part of addiction. Okay, again, not unlike the diabetic who's getting their insulin every day and goes home and has 5 cakes. They're not going to be kicked out by the endocrinologist that they can't get their insulin anymore. So very, very non-judgmental. Client with high comorbidity can only change so fast, so much, so fast. Many of our clients have extremely high comorbidity. One of the things I look for too when they're first coming into treatment is some of that comorbidity able to be helped. They don't have a PCP, yet they have tons of medical issues. Get them connected to a primary care physician. That's going to help with some of the high comorbidity. If you're dealing with the comorbidity, they're going to be more apt to be able to engage more productively in treatment. We're going to talk more about that in a little while. For polysubstance use, most problematic substances is targeted first. We have many patients that come into DBT where there's, again, multiple substances. Do one at a time. In DBT, medications are an accepted part of the treatment protocol. So what does that mean? Methadone is not frowned upon. Suboxone is not frowned upon. Medications are an accepted part of the treatment protocol. For those of you who've been doing this work for a while, I've gone to many AA meetings and sat in. There are many with the framework that if you're on methadone or if you're on some medication, that's not okay. So DBT, again, very non-judgmental approach. Medications are an accepted part of the treatment protocol and should be used to be able to help stabilize patients. Validation. If you take anything from this training today and nothing else, if you could be a clinician, counselor, nurse, husband, wife, family member, friend, validation to any relationship is the key. People do better when there's validation. Validation is the non-judgmental acknowledgement of the client's experience. Validation creates the conditions of acceptance that usually precede change. When I work with patients, them feeling safe, them feeling comfortable to tell their stories, them seeing that I'm not going to judge everything that comes out of their mouth. It's the start. It's the start before change. It's the safety. As a rule, start with validating the client and return to validation when the client is stuck. Still remembering the rules of expectations. When I see a client stuck, but I've seen past success in things, I reinforce that. Remember, John, when you were able to do this. Remember how well you were able to manage the situation. You may be stuck now, but you've had periods of success. Let's reflect on how those periods of success happen. Most effective behavior change methods. Non-contingent reinforcement. Many of you have been a counselor for a while, know a lot about non-contingent reinforcement. Giving reinforcement just to reinforce, not for any specific reason. Model effective behavior. Clinicians, nurses, physicians, we are models. So make sure when we're with our patients, we're modeling effective behavior too. They're looking to us. They're looking to us for that. Reinforce non-problem behaviors. There's many things that our patients do really, really well. Make sure we reinforce that. Make sure we reinforce that regularly. Train skills to reinforce. That's the skills groups. That's the 4 modules. It's all about training skills so that they can use when these difficult situations arise. That's how you change behaviors. So remember, CBT is changing thoughts. This is changing emotions to change behaviors. So training skills to reinforce. You got to give them something to be able to use on the outside, and that's the skill building. Make a high probability behavior contingent on a low probability behavior. Well, what the heck does that mean? If high probability behaviors, the more desirable ones for the clients, okay, those are the behaviors the clients like, are made contingent upon lower probability behaviors, less desirable behaviors to the patient, then the lower probability behaviors are more likely to occur. And that's the big thing. If the client is struggling in an area and we're trying to do contingency management and try to increase the outcome of those low probability behaviors, this is a way to do it. Make a high probability behavior contingent on a low probability behavior. Lower vulnerability and meet organismic needs proactively. If you have clients who have many medical issues, like I talked about, they have a lot of vulnerability right then and there. If they're as sick as can be it diabetes that's not being treated, high blood pressure, heart conditions, it's gonna be very difficult for us therapeutically to be able to help with their mental health and addiction. So we need to lower that vulnerability, getting them connected. I talk a lot about assessment and referral. Assessment and referral is key. It's lowering vulnerability. Harness high-level motivations to lever change. What are they motivated on? My kids are in DCF custody. I want to desperately have them back. That's high-level motivation. How do we leverage that for the change? Use it. How do we leverage that? Harness that high-level motivation to get my kids back from DCF custody to leverage change. Skills training groups. Research shows that skills training groups work independently. So like I talked about early on, that's all I'm doing. I'm not doing DBT individual work. I'm not doing diary card and chain analysis, and I'm not in a consultation group. So research has already shown that you can do these skills groups and they will work independently of those other things. But the research also shows, as part of a comprehensive DBT program, so that's with everything, as a supplement to other types of programs. There's lots of different work that we do clinically, and skills can be a supplement. Remember level of care. It's a big thing. So if you're in an inpatient setting where you're there for 4 to 5 nights, is this going to be the treatment to do? Probably not. So remember the level of care is important in being able to decipher what treatment course to move in. I think we're doing pretty good on time, almost halfway through the deck at 12:33. So DBT skills. Provide a common language for effective behaviors. That's a big thing. So all the patients have a common language. Common language for effective behaviors. Helps the client to label, remember, and use effective behaviors. There's lots of acronyms in DBT, and you'll see some of them shortly. The labeling is important too. For those who are in full-fledged DBT, our patients are doing diary cards every day at home. So labeling is key. You'll learn more about diary cards towards the end of this presentation. DBT skills teach new behaviors to reinforce. Replaces unhealthy and harmful ways of coping. So when you think about emotion regulation, the stress tolerance, and interpersonal skills, a lot of how our patients engaged were unhealthy and harmful ways of coping. So these skills help replace that. And our goal, help clients move beyond abstinence and sustain recovery. So remember, for those who know addiction well, abstinence is just not using. Sustained recovery is a whole different ballgame. Participating in life, working, being a part of your children's life, participating. So it's helped clients moving beyond abstinence, which is just not using, and sustain recovery. Sustained recovery has a whole lot more to it. All right, now we get into each of the different modules and what the module is about. So the first module is mindfulness. Emphasize non-judgmental and acceptance-based experience of the moment. Being in the moment. Again, all of you, my hope is all of you are in the moment. All of you are actively participating in the moment today. Not on your phones, not looking at your emails, not distracted. That's being in the moment. That's a mindfulness skill. Provide a structure for attending to experiences in an effective manner. Helping the clients in situations that will come up. Life happens when you're not using anymore, nowhere to hide. So helping provide the structure for those patients on how to attend to experiences. The difficult experiences mainly in an effective manner that doesn't include use. So attending to experiences effectively. We can't stop experiences from coming. And once you stop using, life hits us. So they have to develop strategies now because for many, many years, they weren't really engaging in life other than use. Build the ability to collect, focus, and sustain attention to then participate in responsive, not reactive behaviors. Awareness and then choice. Right? Many of our patients, they weren't participating. They weren't participating in life. The addiction had the hold. So now they're going to be participating in life, but we got to help them move away from reactive behaviors. Mindfulness is its own container. And essentially what that means, mindfulness as opposed to the other three modules, really it's on its own little island. Mindfulness is the start of everything. Very difficult to teach emotion regulation skills, the stress tolerance skills, and interpersonal skills if you can't be mindful. So if they're in group with me and those patients can't be mindful, they can't be there with me, they can't be in the moment, they can't learn to be actively present, the skills in the other modules, they'll be meaningless because it won't go through, it won't break through. States of mind. So remember, I talked about it's a synthesis. So one of the core concepts of DBT in the mindfulness module, there's emotion mind, reasonable mind, and wise mind being the synthesis. Many of our patients who are highly dysregulated are too often solely in emotion mind. Their lives are consumed by emotion. Everything is about emotion. And when you're living your life from a full emotion standpoint, it'd be very difficult to stay regulated. The other side, reasonable mind. Okay, very by the book. Everything is by the numbers. Very robotic in the thinking. Some of my clients in group will like to say, "Oh, Stephen, that's more like the Spock guy from Star Trek." I say, "Yes." So very, very robotic thinking. Where you want is that synthesis. You want that wise mind, and wise mind is a dialectic. It's a synthesis of emotion mind and reasonable mind. Emotions are good for us. We want emotions. We just don't want to be ruled by emotions. We want reasonable mind. We just don't want to be ruled by reasonable mind. So DBT is about synthesis. Two steps. How do you get to wise mind? Observe and describe non-judgmentally and one mindfully. We're a very judgmental race. And one of the first steps towards getting to wise mind is learning how to look at things non-judgmentally. Seems pretty simple, seems pretty basic. You think about our world right now, there's too much judgment. And a key facet of DBT is learning to look at things in a very non-judgmental and observe things and describe things non-judgmentally. That's how you're going to get to wise mind. Step 2, participate effectively. Be in the moment, be there, participate, be active, be engaged. That's how you participate effectively. States of mind in recovery. So this is a takeoff of what we just looked at previously. So in recovery, there's addiction mind. On the opposite end is substance-free mind, and there's clear mind. Well, why would we look at substance-free mind as maybe just being there as not being the be all and end all? Because you know what? There is still that extreme way of thinking. Because you know what? Methadone is okay. Suboxone is okay. Psychotropics are okay. So if you're going to the opposite end of the spectrum around your recovery, that I must always be a substance-free mind, no, you're going to be inhibited. There's chemical imbalances where we need certain substances to be able to move forward in their recovery. My mom, who's a severe diabetic, needs that insulin, okay? So being at the opposite end of the extreme, the substance-free mind is not where we want to be also. So again, we want that synthesis. The clear mind is the synthesis of the two. All right, slide 20 out of 34. We're doing good. Next module. So, and again, so just so you know, DBT, I went through 80 hours of training. So it's a 2-week course. So we're really condensing this in an hour and a half. So a lot of this stuff we're moving through quickly, and certainly feel free to research some of this stuff more, because there's a lot to it beyond what I'm talking about today. So the second module, and remember I said when I go through this with patients, each module is about 4 to 6 weeks. The stress tolerance skills. Pretty simple premises. Replace unhealthy and harmful behaviors. This module is all about helping patients deal and manage stressful situations. Because, right, if any of us lives life, we're not going to be able to eliminate stress, okay? All of us will have stress in our life. So skills to manage that. Our patients, our clients, they're much more vulnerable, so these skills are even more important to them. So they help replace unhealthy and harmful behaviors. They help to survive crisis without making it worse. It's a big thing for our clients. We'll hear them talk to us about crises, and we hear them explain the situation, and we also see and hear how much they've made it dramatically worse, right? We've seen that time and time again. They talked about a crisis, and the crisis was at one level, and then based upon their reactions, it became an altogether different level. So crises are going to come up. So these skills help our patients survive a crisis without making it worse. So not having that small relapse turn into a binge where they disappear for months. So how to help survive the crisis without making it worse. These skills must be learned and practiced proactively. Yeah, that's a big thing. I can't teach something in the DBT group and they never use it. That's where the diary cards come in. That's where the chain analysis comes in. And that's where the individual work comes in with DBT. So again, I'm not doing it to the full-fledged DBT, but anything with skills. You don't use it, the saying is you don't use it, you lose it. So these skills must be learned and practiced proactively. They got to use the skills. Put into a written plan, diary card, chain analysis. They would bring that back to the individual session, and we see what's going right, we'd see what's going wrong, and we'd work to adapt. All right. So like I talk about in DBT, there's lots of acronyms. So some of the skills, one of the first ones we talk about is accept. And it's activities. So Engaging in activities. So when you're stressed, go do something. Do something active. I know when I'm stressed, going to do something that takes my mind off the stressful situation helps. I like to garden, one of my coping skills. Contributing. You stress, contribute. Giving back. Volunteering. It's a skill. Comparisons. One of the great things that people get from groups, I think they're able to see, wow, I know my situation is difficult, but hearing from James today, their situation is so much more challenging. Comparisons, different emotions. If you're sad, maybe go watch a comedy. It's all about the accept skills of distress tolerance, pushing away. Leave something, put it down for a moment. Push it away for a while with other thoughts, thinking about some other things. With sensations, cold shower. So some of these seem pretty benign, but again, for our clients, there are no basic skills. So sometimes we're starting from scratch, and it's getting back to the basics with many of our clients. So accepts is a form of distress tolerance skills. Again, I'm going through it really fast. There's a lot more to it, but I'm only covering it briefly here. Improve the moment with imagery. So thinking about things, imagine if you can't get to a park, imagine being in a park, looking at the flowers, walking around on the beach with meaning. Improve the moment by finding other things in your life that are meaningful, that are important for you to be around for, that are important for you to live for. With prayer, we have many clients that have religion is important to them. Relaxation, mindfulness exercise. One thing in the moment. Move away from doing 5 or 6 things, which can make increased stress happen. Do one thing, do that one thing well, focused on that one area. With a brief vacation, just leave everything for a while. And that vacation doesn't have to mean a trip. Not everyone has the monetary means to go do that, but vacations can mean very different things. It can mean going for a ride, someplace that makes you feel good, where it has positive memories. Self-encouragement and rethinking the situation. We talk a lot about this in DBT. Positive self-talk. I do it. Encouraging ourselves, positive self-talk. You've gotten through stressful situations before. You can do it again. Here's how you've done it. Self-soothe. Pros and cons. We've all done this, but we teach our clients how to do it. What are the pros of moving through this situation? What are the cons of remaining in this extremely stressful situation? Having them jot that down. Radical acceptance. There are some things we cannot change, going back to the Serenity Prayer. Some things, no matter what, we can't change. But the goal of radical acceptance is helping our patients move out of suffering. Radical acceptance helps us move away from suffering. Doesn't mean we condone the situation, but it helps us move away from there. We want to move away from suffering. Willingness. Everything starts with willingness, right? If there's no willingness to be able to move through the situation, there's going to be no ability to be able to get away from intensely stressful situations. Okay, so we've gone through 2 modules so far as the types of skills they use. We've gone through mindfulness and distress tolerance. Now we're going to go through the 3rd module, 1250. I think we're doing okay. 3rd module, emotion regulation skills. So again, this module is about 4 to 6 weeks. Teach our patients how emotions work. Emphasize self-care to decrease emotional vulnerability. And I'll talk about that in a little while. Think about our own work. You know, the work we do is extremely emotionally draining. Self-care, very important. So emphasize self-care to decrease emotional vulnerability. Increase positive emotions. What are some things that make life enjoyable for us? I have one patient talks about whenever she's with her grandchildren, her positive emotions zoom up. So if there's ways to spend more time with those grandchildren, put them in place. The more positive emotions we can put into our life, the more positive experiences, the more we're going to be able to manage those difficult times. Because we have other opportunities in life. Step out of ineffective mood congruent behaviors. We know that there are situations that constantly put us in a bad mood. Let's try to figure out how to either change those situations, because sometimes leaving those situations is not possible, but figure out how to change those situations so we're not in that ineffective mood state. So some of the skills in emotion regulation. The please skills. So we talked about emotional vulnerability. Treat physical illness, that's the P. So the P is treat physical, it's the P and the L actually. So treat physical illness, right? If you're sick and you're not treating that, it's going to exacerbate mental health and addiction. Balanced eating. Whenever I'm meeting with a patient, oh yeah, I've, all I had today was a bowl of cereal, whole entire day. Balanced eating, not having balanced eating is going to impact our emotion regulation. These things we know, there's science, these things impact our emotion regulation. We know that. Avoid mood altering drugs, that's the A. We know that. Balanced sleep, the S. So thinking about that. How effective are we if we're on a few hours sleep? Imagine our clients who are less skilled. It's going to impact their ability to do emotion regulation. And the last part, so the last part of the please emotion regulation skill is E, exercise. Science, exercise releases endorphins. We know that. You feel better. If you feel better, your mood is going to be more regulated. So again, very important emotion regulation skills. So that's the please. Build mastery. When we start to build mastery in anything, we start to feel better. What are we good at? What do we like? Build mastery. That's going to increase your ability around emotion regulation. Build positive experiences. Have that positive experience deck. Gardening, playing sports, going to the gym, spending time with family, going to a coffee shop, going to the park. Have a positive experience deck of things that you can go to and revert to when you're feeling emotionally dysregulated. Then the last skill, opposite to emotion. Change the emotion by acting opposite to its action urge. What does that mean? If I have a fear of something, it's an emotion, right? I'll avoid the situation. The opposite of that, if you have the fear, go right at it. Face your fear. Use the opposite action urge. Face your fear, deal with the situation. You're skillful now. So the opposite to the emotion. Change the emotion by acting opposite to what its normal action urge is, which might be retreat. I'll talk more about that shortly. Next module, our last module, interpersonal effectiveness. And lots of acronyms here. So again, interpersonal effectiveness is helping our patients learn how better to maintain relationships, manage in relationships, and a very, very important one for many of our patients that we spend a lot of time on in interpersonal effectiveness module is how to end relationships, move away from relationships that are destructive. It's a big one for many of our patients, how to end relationships that are destructive. So the interpersonal effectiveness module goes through some of these skills, and also how to learn to get your needs met. Okay, for many of our patients, understanding how to get their needs met is very difficult. So interpersonal effectiveness, how to get your needs met, wants, how to engage in relationships better, how to have productive relationships, long-lasting relationships, and the most difficult thing, ending relationships that are challenging. Increase self-respect. Fast. Hold on one second. Be fair. No apologies, stick to values, be truthful. So what FAST is around, it's around you speaking to someone in your life and figuring out how the best way to approach an interpersonal situation to be able to get your needs met. Be fair. Make no apologies for wanting to get your needs met. The S, stick to your values and be truthful. How many of our clients don't know how to build and maintain relationships. They struggle with this. So we teach them skills, how to be able to do that. One of those skills, the acronym, we call it GIVE. Any relationship, we want to be gentle, right? Being harsh doesn't work. Act interested. It's a didactic conversation. Validate. And any good relationship has lots of validation. Use an easy manner. Don't be gruff, don't be harsh. Again, these are skills to help our clients maintain new relationships. Many of their relationships have been built off of addiction. Those relationships aren't good for them anymore. So how do you work at getting new relationships, or all of your relationships before were about the commonality was use. Increase assertiveness. It's another big thing. Many of our patients also have been walked on for many years, taken advantage of. So we're working with our patients to increase assertiveness. Learning how to say no and setting boundaries. The skill here, we call it is Dear Man, one of the most popular skills in DBT, the Dear Man skills. Describe the situation to the person you're trying to engage in this conversation with. Express your feelings. Assert yourself. Reinforce why this is important to you. Why you must say no. Stay mindful. Mindful means being in the moment. Appear confident. You know, you're further along in your recovery now. You know that you've learned some skills. Show that confidence. Sometimes we do have to negotiate. There is give and take. So that's the Dear Man skills in interpersonal effectiveness. Special emphasis with interpersonal effectiveness. We use interpersonal effectiveness skills to refuse substances. We talked a little bit about that when I went over on the last slide. The ability to be able to say no. For many of our patients, that was a struggle. So now we've given them the Dear Man skills on how to refuse substances. How to address resentments. Resentments are tough. Think about our own lives. Resentments can impede growth, can impede progress, can truly impede recovery. Interpersonal skills also teach us how to go back and make some amends. You're more ready for it when you have these interpersonal effectiveness skills. All right, very good. Still doing well. Dbt Power Tools. I don't use these things in my DBT skills group, but like I mentioned, they're very important for full-fledged DBT. The diary card. Again, it's a self-monitoring card, and I'm going to talk more in depth about that on the next slide. Behavior and solution analysis to recognize patterns in use and skills to change behaviors. I like to call this ABC analysis. For those who might be familiar with that, antecedent, behavior, consequence. Antecedent to what happens before the behavior, what is the behavior, what's the consequence after that. Understanding behavioral analysis helps you put in new skills to create change so that negative behavior doesn't continue to happen over and over and over again. So what are diary cards? Self-monitoring of urges, target behaviors, symptoms, skills, emotions, and other important information. It's really where they're jotting down everything that's happening related to those things we just talked about in the top line. And then how skills interact with that. Helps to structure and generalize what is learned in therapy, okay, those skills, to natural environment, and builds awareness and skill use. I wish I could do the diary cards with the patients, to be quite honest, but it's just, the work I'm doing is just not set up conducively for that. Provides a tremendous amount of information to track how the client is doing, determine if there are target behaviors on the treatment hierarchy to prioritize, and to set the treatment agenda. It's their homework. It's their daily homework in between group and individual session. And then when they bring that card back to the session, it provides opportunities to positively reinforce success and to inquire about extra therapeutic factors, meaning maybe there's more that they need, and that's the time to further refer. But the big thing that I like about the diary cards, you know, they're able to bring that back. They love when they see how successful they were, and they show you that on the diary card, and you're able to reinforce that. Great feelings that come with that for the client. We all love and need positive reinforcement. Our patients are no different. Guidelines of the diary cards. Orient clients to why the diary card is important and how it will help them reach their goals. Not everyone likes homework, so I have to spend a decent amount of time why this is important. They like to go to group, they like to go to individual session and be done. But in true DBT, the diary card is an important homework piece. Completed each day, preferably at the same time for the previous 24 hours. You review the diary cards at the beginning of every session and use the information to set the agenda with the clients. So really, I would take that diary card at the beginning, we'd review it. The rest of the individual session that day relates back to that diary card. Sort of sets the tone for the rest of the session. Address incomplete diary cards as what they call it in DBT, TIB, treatment interfering behavior. Why are they not doing it? It's a treatment interfering behavior. Try to get at the why of that. But you address incomplete diary cards in that individual session as a treatment interfering behavior. So the second part of this, purpose of behavior and solution analysis. Develop a picture of what becomes before a behavior. So the diary card helps us understand. So if a person wound up using today, and maybe they haven't for a few weeks, and I see that diary card, I want to see what was happening before that behavior. Did they see their ex-husband, their ex-wife, their ex-girlfriend that morning? So what was the antecedent? See if we can determine an analysis of the behavior. Develop a picture of what comes after the behavior. Well, in this instance, they used. The consequence. Understand the context that surrounds behaviors. Use this understanding to actively problem solve and develop skill use. Okay. If you have to see your ex-husband every Tuesday at 6 p.m. to drop off the kids, and then after you have that interaction is when you go use the antecedent, we have to figure out what we can implement in this situation, because you can't eliminate that situation. You have to get your kids back, the transfer of the kids for the custody agreement. So then you problem solve. You found out, all right, this is an antecedent that causes problem behaviors. If we can't change that antecedent, what skills can we put in place to help you manage that better? Behavior and solution analysis. How to frame behavior and solution analysis. Some clients experience change analysis as punishment. If this happens, again, everything goes back to validation. This happens, be sure to validate the experience. It's a big thing. It's tough to be able to look at that on paper. I see my ex-husband, I use, and now you're going to need me to talk it through. So be sure to validate the experience. Discuss how change analysis is a learning tool to help clients reach their goals. If you sit with them to help them understand their behavior and be able to change and implement new skills, it's going to further get them to what their goals may be. Maybe it's to get back to a full-time job. Maybe it's to get those kids back from DCF custody. Always go back to validation and the long-term goals that the client talked about. Slide 31, we are almost there. During the behavior and solution analysis process, orient clients to the procedure, show them what this means and how we're working this through, and continue to orient as you go through the change analysis. Again, why is this important to the client? Keep coming back to why this is important. Why understanding the reasons for the behavior through the chain analysis is important to help the client reach their goals. Validate the emotions that arise that change analysis can be difficult. Yeah, sometimes it's no fun going through this process. And this is done through the individual DBT session. Attending to emotions also provides exposure effects. If they become emotional in the situation, that exposure in that moment can also help the clinician work through skills right then and there in that moment, an exposure effect. Use positive reinforcement for efforts and breakthroughs. Big thing. I love seeing those diary cards and reinforcing them as much as I can, especially around breakthroughs. When you've seen a change analysis and you see how a pattern of behavior that was not adaptive and was maladaptive has now totally changed, a breakthrough. Remember that the end goal is to learn skills and solve problems. That's what all of this is about. It's to learn skills and solve problems. Use is no longer an option. There can't be the running away from problems. It's the recovery portion now. Sustained recovery. So for sustained recovery, you need skills to be able to solve those problems. Use is not a skill. Coordinate what is learned with crisis, safety, and other skill plans. If you have a crisis and safety plan, you have to learn to be able to adapt those plans and adjust them accordingly based upon breakthroughs and what's changed. So steps in behavior and solution analysis. You want to know what the target behavior is. Let's say it's use, it's substance use whenever there's emotion dysregulation or there's stress. Ask about the frequency, intensity, and duration of the behavior. It's happening 5 times a day, an hour at a time. Go step by step until you have a clear picture of the following. What made the client vulnerable? We talked about the incident before, seeing the ex-husband. What was the prompting event that triggered the transfer of the kids back to the situation? What are the links between the prompting event and the target behavior? The emotions, the thoughts, the physical sensations, other behaviors, everything gets written down. What is happening or not happening in the environment? All on the diary card. All of that stuff, that's how you do a proper analysis. Anything, we need data, right? We talk about data all of the time. Data helps us create change. What are the consequences of the target behavior? Is there negative reinforcement? Is there positive reinforcement? Step 4, go back and have client hypothesize possible skills to use to address vulnerabilities, intervening links, as well as skills to replace target behaviors. Go back to them. You know these skills, John, okay? what are some of the skills you could have used? We've gone through emotion regulation. So instead of letting your emotions take over and using in this instance, tell me, reflect back to me, what are some of the skills you could have used in this situation instead of use? They've learned this, they've learned the module. Have client problem solve how to skillfully deal with consequences so they do not develop into vulnerabilities. Not always going to get your way. There's going to be consequences. And it can't be that from those consequences, you're going back to use. Consequences don't disappear for us. So how do we move away from that developing into a vulnerability that creates use? Have client develop a plan to make amends with others for the target behavior if applicable. 12-step programs, making amends is a key one. We'd like to talk about that here as well. As you advance your skills, as you become more skillful, especially in your interpersonal skills from that module, amends is going to be more easy to be able to move through. Get commitment from client that he or she will actively practice the identified skills. Big thing, I need to get a commitment. Can't be treatment interfering behavior. If they want to be in DBT group, I need their active commitment that they're going to practice those identifying skills. If they don't want to practice, then they shouldn't be in DBT. It's a treatment interfering behavior. One of the main things for those who are in DBT with me, my one request is that you need to come with an open mind. If you come to session with a closed mind, there's no opportunity for growth and change. So if you're unwilling to practice the identified skills, then there's not going to be any opportunity for change. In summary, DBT has been shown to be effective in research, and it could be expected to be effective in practice when applied with belief and expectancy in a structured and coherent manner. So, efficacious. Data has supported the research around this being something that produces change. A strength of DBT is teaching skill sets to help people overcome deficits, achieve abstinence, and then move into sustained recovery. This is, and bullet 3, this is what I do. DBT can be used as a standalone treatment or thoughtfully combined with other structured approaches. So I don't use every component of DBT, but there's benefit from the skill groups that the clients are gaining without going through the chain analysis, the individual DBT group, and the diary cards. So that is all of the slides. So in 1:15, we do have 15 minutes for questions. I'm not even sure I know how to take questions on this, so Darcy may be having to help me. But what are questions that people have, if any? Darcy, I don't know if any questions are coming through, and I just don't know how to be able to see it. Maybe if
no written questions yet.
Where is that? Let's see.
It's down in,
I see
in chat.
Okay. I see. Where can you get this training? Okay, that's from Eleanor. The DBT comprehensive training that I went through, again, is 80 hours. It was 2 weeks. You came for 1 week, and I did it in Northampton, Massachusetts. So Eleanor, I might check out Northampton and see, plug in Google Northampton DBT and see if anyone's doing it. So there are other folks that do trainings periodically for like a half a day or a full day. That's not the DBT intensive. So the DBT intensive is that full 2 weeks. And Eleanor, you could email me separately if you struggle finding something. Caitlin, thank you. In your opinion, which skills module would you prioritize for clients new to DBT? Well, mindfulness is always the first module we do, because if you can't understand mindfulness, then it's going to be very difficult to move through anything else. If you can't be in the moment, if you can't learn how to be in the moment, then you're going to have very difficulty doing any of the other modules. So I would say, Caitlin, that one, and that's why it's the first one when you go through DBT. Can we get a copy of this PowerPoint presentation? Let me think about that, Conchetta. And I'm not sure. Are you in this organization? Yes?
She is.
Okay, so email Darcy and we could talk offline. Chris, I love the notion of radical acceptance. Practically speaking, though, how does it help people from having reactive behaviors? What does practicing look like? Radical acceptance is probably my favorite part of DBT. I think it's not so much for me focusing on the reactive behaviors. I have one client in particular who has suffered a great deal of trauma in her life, a great deal of sexual abuse. And it really inhibited her over the years from being able to move forward in any real way. So we spent a lot of time talking about radical acceptance and not condoning what happened, because it was really interfering, that trauma. And it would happen. A lot of reactive behaviors would happen as a result of that, until she was radically able to accept, we can't change that. It's the most awful thing imaginable. We can't change that. But for me to move away from the constant suffering, the constant reactive behaviors, I have to radically accept that trauma to be able to now to move forward with my life of recovery. And that'll be the best I'll show you that you can really do. So I'm not sure if I quite answered your question, Chris, but that's how I engage with the client around that. What else? Any more? I'm not seeing more after Chris. I was hoping for more. Okay, there's another one. Dr. Podolsky, are there certain types of therapy better suited to use in conjunction with DBT? For example, does DBT work well alongside with DBT, or should one be done before the other, or is it counterproductive? That was a long question, Doc. To do both at the same time. Also, are there certain schools of therapy that don't mix well with DBT? One of the things that I think work well with DBT, and I mentioned it earlier, and I'm not officially trained in this, but if you know enough about motivational interviewing, I think that's a good framework to be able to use accordingly with DBT, because it's around helping motivate and moving clients forward in direction using some of the basic skills they already have and the basic beliefs that they want to change. So I would use motivational interviewing, if you have that, more so than CBT. What else? Also, internal family systems. Yep, I'm not familiar with that, but sure. Yes to internal family systems. Perfect. So it sounds like there's another answer to Dr. Podolsky's question. What else? Samantha, which module would you say is typically the most difficult for a client to comprehend and utilize? I know it's the most difficult for me is mindfulness. I struggle with that immensely. Being in the moment is tough. And I think I've seen that be the most difficult for clients as well. It's also the foundation though for everything. So that is a struggle. In the day of social media, in the day of quick action with computers and information at our fingertips, getting people to be in the moment, getting people to act mindfully, to engage non-judgmentally is very challenging for me. And I see it the most challenging module for our patients. Too much stimuli, agreed, yep. What else? We have 10 more minutes if people have more questions. And if you also, as an aside, you come up with a question later, you could also email me offline as well. What else? Is Samantha it? I'll give it one more minute. Still have about 81 people on. All right, it looks like we have no more questions. So if you have more questions, and maybe you didn't want to do it in this capacity, and you prefer to email me, certainly do that. An old friend, Jonathan Simpson. Good to see you, buddy. You can email me at steven.zuckerman@rootcenter.org for those folks like Jonathan who are not in the org. All right, take care, everyone. Be well, and I'll see you all soon.